Hello, everyone. My name is Jessica Porras, and I am the Senior Manager for Education and Outreach at CAQH Core. It is my pleasure to welcome you today to our fourth and final CAQH Town Hall Webinar 2016. Before we begin our session, I'd like to mention a few logistical items. You can download a copy of today's presentation from the CAQH.org website after the end of the session. To do so, navigate to the Core pull-down menu at the top of the CAQH.org welcome screen and select the Core Education Events page. A link to the PDF version of the presentation can be found under the listing for today's webinar. We will save time at the end of today's program dedicated to responding to audience questions. You are encouraged to submit your questions at any time during this webinar by typing them into the questions panel of your dashboard. We have a lot of information to share with you today. First, we will start off with a high-level CAQH Core regulatory update, followed by several presentations on our current rule writing activities, including core code combinations maintenance, enrollment datasets maintenance, and prior authorization. We will then share the latest information on voluntary core certification, and then our Managing Director will give an update on core activities looking forward, including our certification activities related to market share, attachments, and value-based payments. Now, I'd like to introduce our first speaker, CAQH Core Director Denise Benning. Denise?
Thank you, Jessica. With all of us in the healthcare industry moving at lightning speed, sometimes it's a good idea to stop and reflect on why HIPAA and the use of standards and operating rules is so important. The CAQH Index is the industry's annual litmus test of the healthcare industry's ongoing transition from manual to electronic exchange, reporting data from more than 4 billion transactions. In its 2015 report, the CAQH Index estimated that for only 6 of the HIPAA transactions for which standards and operating rules have been developed, the direct labor savings for these transactions alone would be over $8.5 billion. Imagine if someday HHS adopted or the industry voluntarily used standards and operating rules for all of the HIPAA transactions. The savings opportunities would soar into the many billions of dollars. So keeping that in mind, let's just quickly review. The Affordable Care Act mandated that operating rules be developed for all of the HIPAA transactions for which HHS has adopted a standard. The first phase of the HHS mandated operating rules for health plan eligibility and claims went into effect in 2013. The next set, for electronic funds transfer and remittance advice, was mandated by HHS as of 2014. The next 2 items are currently on hold or voluntary. First, the ACA stated that health plans must certify their compliance with operating rules and their underlying standards or face stiff penalties. HHS has indicated that a new proposed rule will be issued on this in the second quarter of 2017. Second, the Phase 4 operating rules for claims, referrals, enrollment and disenrollment, and premium payments, which were approved by an overwhelming CAQH Core vote, have been in place. Also to be considered is the development of operating rules for claim attachments, for which HHS has not yet adopted a standard. The National Committee on Vital and Health Statistics, the advisory committee to HHS, has strongly endorsed voluntary use of the Phase 4 operating rules. Any future regulatory action on the part of HHS is yet to be determined. So the NCVHS and the ACA Review Committee met recently, and there are some new developments of note. As with the upcoming presidential election, there will be changes to the leadership of NCVHS. Dr. Walter Suarez's term as chair ended in mid-October, and he has been succeeded by Dr. William Stead of Vanderbilt University Medical Center. And there's also another vacancy on the committee. The CAQH Core Board previously sent a letter to the department asking that any candidates for vacancies on the committee be from healthcare entities with implementation experience. At the meeting, CMS also announced that their asset tool for submitting HIPAA violation complaints has been updated and is now available for use. The NCVHS meeting also was the venue for the ACA Review Committee, mandated to gather industry feedback on the utility of the HIPAA transactions, standards, code sets, identifiers, and operating rules. It presented its findings, which summarized the comments that the review committee heard during its June hearings. The committee approved their final report for issuance to the HHS Secretary. And finally, the NCVHS Subcommittee on Standards teed up a set of potential priorities for next year, including development of a roadmap for future HIPAA updates, a report on the future of HIPAA, discussion of the initiative to replace Social Security numbers on Medicare cards, the potential adoption of an all-payer claims database, and a national patient identifier. If the NCVHS gets to just a fraction of these projects during the next year, it will be a very busy time for not only CAQH Core, but for the industry at large. That's our regulatory update. And now, back to Drew with our first polling question. Drew?
Great. Thank you so much, Denise. And this brings us to our first of three audience pollings that we have for the webinar. And I will read the poll, and then you'll see a window on your screen pop up for everyone to log their response. So this question asks, which is the highest phase of the CAQH Core operating rules that your organization has implemented to date? And so we'll pause for just a brief moment, and you should see the poll available on your screen now to answer. And I will share the results and perhaps get some feedback from our presenters before we continue on. Pause for about 10 more seconds. And maybe Denise, since you just spoke, I might have you comment a few words here. Take about 3 more seconds here. All right, I will close the poll and share the results. Well, the largest majority, 49%, indicate that phase 3 is the highest phase that they've completed. 27% indicated they were unsure, 14% saying that they're not an implementer, and then 6% saying phases 1 and 2, and 4% saying phase 4. Denise, really quickly, what do you make of these results?
Well, I think they're consistent with what we've seen, especially in phase 3. We still have a long way to go. And of course, if you're phase 3 certified, you're also certified in the previous phases as well. I think it's interesting to note that we have 4% saying they're implementing phase 4 because phase 4 has just been recently in the marketplace, so to speak. So for those who voted and said that they have implemented phase 4, we'd sure like to hear from you and hear about your experiences with implementation. So feel free to contact us at our email address and let us know what your experience has been.
Great. Thank you so much. And now we'll continue today's program with 3 presentations on CAQH Core current rule writing activities. First, we'll have Bob Bowman talk about the core code combination maintenance activities. And then Ami Adekambi will talk about the upcoming core code combination market-based review. And then finally, Aaron Weber will present on the core enrollment data set maintenance and prior authorization work. Bob, take it away.
Great, thanks, Drew. And Drew is exactly right. We do want to provide you with a quick update on where we are with our various groups and what activities we've been taking with both our mandated rule set as well as our voluntary rule set. As you can see here on this slide, we do have 3 different groups that are going to be doing a lot of work over the next few weeks. And that includes our code combination task group, our core enrollment maintenance task group, and our core certification and testing subgroup. Each of those groups will be meeting either to fulfill their role as maintaining those rule sets, as well as provide updates to those subgroups as well. Additionally, we will also be launching our core participant survey on potential additional prior authorization operating rule opportunities. So this will be very important as we think about and move forward with rule opportunity areas for prior authorization, a very hot topic in the industry. We will also be issuing an interim report on the value-based payment opportunities for the industry action. So really all of this is to say that there's a lot of work going on, even here towards the end of the year and into the next year. And if you'd like to participate, we really want to get as many stakeholder types and many stakeholders to be involved as much as we can. So please reach out to us to make sure we can add you to the roster for any of these groups that you have a particular interest in. We want to make sure that we get you added to those rosters and you're part of that process. Now I'd like to move into a specific update on the core code combinations task group and what we're doing for the phase 3 operating rule set. Moving on to the next slide, you can see that the core is responsible for maintaining the core code combinations that we have in the marketplace. And these include code combinations for the CAQH, the RARCs, and the group codes. And these codes used in combination are what health plans convey to a provider when they have adjudicated a claim, and they provide a specific reason for a denial or an adjustment either at the claim level or at the line level. So these code combinations are really important because it provides very specific information that providers have to take on a specific bill. If we move to the next slide, you'll see that there are very specific reasons why code combinations and why specifically core code combinations were so important and why we have to maintain those. Beginning with providers, there was lots of confusion within the healthcare industry, not just providers, on what the codes are, how to use them. How do you map a proprietary code into a standard code set or a standard code list? Providers didn't receive uniform and consistent code combinations from health plans, so it always required lots of manual intervention. So providers had to go to specific websites or web portals for a health plan, understand what this code combination really means, so it really was a burden for the providers. Also, there's hundreds of different potential code combinations that they could receive because every health plan had their own internal proprietary codes, their own internal business scenarios, and they did everything on their own. Well, now with the core code combinations, we'd be able to resolve some of those issues. Additionally, a lot of those code combinations that health plans were putting together really had a lot of subjectivity, a lot of interpretation. There wasn't a lot of industry discussion about how health plans put these code combinations together. Additionally, the codes are updated 3 times per year, so providers and plans were not using the most current code sets available. Sometimes they're even using deactivated codes, and this would cause problems with their remittance advice. So there's lots of potential problems with the universe that these codes address. And now with the core code combinations, as you can see on the next slide, still trying to address this problem of before the code combinations existed, providers would provide care. They would bill that claim to the health plan would adjudicate that claim, and that claim would have specific errors. The health plan would deny the claim or certain lines on the claim or adjust those lines on the claim, and the provider really had no way of knowing specifically what that particular health plan was asking for. So there's lots of confusion because the CAQH and RARCs for one health plan that they used for one scenario was completely different than the CAQH and RARCs that were used by another health plan for the same scenario. And so the provider had to know exactly what they're doing for every single line item, and it became very, very confusing and burdensome for the provider. Once the core code combinations came into place, the provider can render the care and bill the service to the health plan. The health plan still adjudicates the claim. They would submit the remittance advice back to the provider. And the provider would be able to see specifically, because every provider is now receiving a consistent and uniform set of CAQHs and RARCs for 4 business scenarios. And those specific 4 business scenarios relate to about 80% of the problems that providers reported in having. And most of these related to missing documentation, missing data, or billed services that are grouped together, or bundled payments, or bundled services. So these types of scenarios where the code combinations have really been impactful allows the providers to more easily identify the issue and then rebill. Let me move on to the next slide. You can see that there are very specific processes that are in place that the core code combinations task group perform. We look at the updates to the standard code list and complete a compliance-based review 3 times per year. Again, this includes any adjustments to align the core code combinations to the published code list, as well as once per year, we conduct a market-based review. And this is where the industry business needs are brought into this process to ensure that health plans, providers, vendors, and clearinghouses have a way to adjust those core code combinations to ensure that they're meeting current business needs. And these 4 business scenarios all kind of work through this process of each one of these code combinations are being reviewed 3 times per year to make sure that they are consistent not only with the standard code list, but also with the industry business needs. And moving on, I believe we'll hand the call over to Omni to provide an update on the 2016 market-based review.
Great, thank you, Bob. So as Bob mentioned, once a year, CAQH4 conducts an industry-wide survey to collect submissions for potential adjustments to improve the core code combination. This survey is targeted towards implementers of the code combinations, excuse me, who are having challenges or opportunities that can address by adjustments to the core code combination. So perhaps you are a health plan who keeps getting phone calls or emails from providers about a specific billing situation, have been thinking, it would be great if there was a standard code combination to address this. Or perhaps you are the provider who keeps having to call a health plan to get clarifying information on the same code combination and want to have it removed. Or finally, perhaps you are a government entity that has a specific statutory situation or Medicaid benefit that you've noticed is missing from the code combination and you really need to get it added. If any of these situations sound familiar, then the Market-Based Adjustment Survey is the solution you need. The 2016 Market-Based Adjustments Industry Survey is open to all core participants and any industry stakeholder that uses the claim payment denial code. The survey will open on November 21st and close on January 21st, giving the industry 60 days to submit potential adjustments. This will be your time to submit any potential adjustments to the code combinations to ensure that they meet your individual business needs. Via a standard online form, entities can request additions, removals, or relocations to the code combinations in the existing scenarios. To ensure submissions are well supported, the form asks respondents to confirm that the requested code combinations adjustments meet the core code combinations evaluation criteria, have a strong business case for their use, and optionally, to include a summary of real-world usage data that demonstrates the business case. While the industry survey opens in late November, there are steps that you can start taking now to be sure that you are ready to submit your response by the January 1st, 21st deadline. First, you want to start getting your team together to work on your entity submission. Usually there are a few people across different offices, perhaps coding departments and AR staff, that you may need to consult. Once you have your team together, you may want to begin to compile your data and start putting together a list of recommended adjustments to the core code combination. To accomplish this, you'll want to concentrate on reviewing billing and AR data to identify areas where your organization has experienced confusion in auto-posting, or if you are health plan, you have experienced the most follow-up. You'll also want to determine which CAQH and RUC combinations cause the most confusion in your billing, and particularly identify if these code combinations are included in the core code combination. If they are, perhaps there's a code combination you want to submit for removal. Or perhaps there is a better code combination that should be added instead. If the confusing code combination is not part of the core code, perhaps there is a way that adding it to the core of the scenario would make the scenarios clearer and easier to auto-post. You will also want to collect usage data related to the code combination. For example, how often do you receive a confusing code combination? Do you receive it once a week, dozens of times each week? How much of an impact does the manual processing have on your team? Once you have all of your data analysis prepared, you will be ready to submit your response to the industry survey. And I will now hand it back to Drew for our second polling question.
Great. Thank you very much, Ami. And this brings us to our second polling question. And just like last time, I will read the question and then launch the poll. And then Bob and Ami, I might have you provide us just a few quick words before we carry on. So this question asks, for your denial remittance advices that require manual follow-up, select from the following the reasons for that follow-up. And this is select all that apply, so there might be more than one. And you should see that come up now. And so we'll pause very briefly. And please take just a few seconds rather, to answer this poll. And then I will share the results. take about 10 more seconds. We realize not everyone on the call might work with this, but we'll still take your answers nonetheless. About 5 more seconds. All right, I'll close the poll and share the results here. So we see 53% indicating that the CAQH combination was unclear, corrective action rebuild, followed by 50% saying CAQH combination was unclear, mismatch between CARC and RARC descriptions, 33% saying a lack of coverage, CAQH combination was unclear, and then 26% indicating the group code was unclear, inaccurate assignment of financial liability. So Ami, I see you looking at these results. What do you make of them?
Well, first I'd like to say this is fantastic information for us to have, and it's very informative. It's useful to know that the real challenge with manual follow-up is not knowing what the corrective action is that the provider needs to take, or a mismatch between the CARC and RARC descriptions. Those are issues that can be readily addressed, especially if we have that error in our code combos. We can definitely, with our task group, work on addressing those and making sure that it's clear. I think our task group works on that a lot, that the provider knows at the end result what action to take, or making sure that we don't have a misalignment between what the CARC is telling me to do and the RARC is telling me to do. If you find those and you're experiencing that, definitely send in a survey response and let us know about it. We would be more than willing and happy to address it.
Fantastic. Great. Well, thank you very much. And I'll close that out, and we'll carry on to Erin, who will bring us through the next section.
Great. Thanks, Drew. I first want to touch on another area of maintenance with regard to the Phase 3 operating rules, and that is maintenance of the core required maximum EFT and ERA enrollment data sets, and these are found in the enrollment data operating rules. These rules recognize, well, first, the rules contain a set of enrollment data elements that must be collected when a provider enrolls in EFT or ERA with a health plan. And the rule language recognizes that there may be need to adjust the data sets due to emerging, new, or changing industry business needs. And it has a requirement for an annual maintenance process. That process kicked off 2 years ago with the final rule from CMS, and the CAQH Core Enrollment Task Group oversees the maintenance of the enrollment data sets. They set forth some key policies which are outlined on our website as to how this maintenance process will work. There are 2 types of reviews that alternate each year. The first is a limited review, and that is the type of review that the task group is actually currently conducting now in 2016. A limited review addresses only non-substantive adjustments to the data sets. So are there, typos or grammatical areas that could be adjusted to make the data sets more clear and user-friendly? With this type of review, there would never be a change that would require HIPAA-covered entities to update their enrollment systems or forms. The second type of review is a comprehensive review, and the next comprehensive review is scheduled for 2017. The task group did consider conducting a comprehensive review last year, but after consideration elected not to make any substantive adjustments. So in 2017, the task group will consider both substantive and non-substantive adjustments submitted by users of the operating rules. If any substantive adjustments would be approved by the task group, HIPAA-covered entities would need to update their enrollment forms or systems, and the website lays out the timeline and process for doing this. So, like I mentioned, in 2016, the task group is only conducting a limited review, so there would be no updates that HIPAA-covered entities would need to make to their systems in this year. If you're interested in getting involved in this task group and you're a core participating organization, email core@caqh.org and we can get you set up with the limited review process. I'm now going to pivot a little bit from our Phase 3 maintenance activities to prior authorization, which is an area addressed by one of the Phase 4 operating rules. And during that rule development process, it was recognized that the infrastructure requirements in the Phase 4 prior auth rule really set a foundation, but that more was needed for the industry to move towards
fully electronic prior authorization given the low adoption rate, which is around 10% across the industry, according to the CAQH index using the 278 transaction. So CAQH Core is launching an effort to consider additional voluntary prior authorization operating rules this year and into next year. So build off of those infrastructure requirements. There are a set of potential opportunities has been drafted, which include 5 key areas: data content, workflows, formats, transport, and utilities. So there's a lot of different ways to address the challenges with prior authorization. And it may be that not one particular way will solve all of the problems. So the core participants will be considering a myriad of approaches to help drive electronic prior authorization. The next slide outlines a high-level work plan on how this process will begin. And really, this timeline here is just the first step to the broader rule development process. So as I mentioned, a list of draft opportunity areas has been identified based on core public surveys, feedback from NCBHS, ACA review committee work, etc. So CAQH Core has formed a prior auth advisory group, and this is a small group of multi-stakeholder organizations that are implementers of prior authorization. We're going to help vet this opportunities list, and that group is providing guidance on a broad environmental scan conducted by CAQH, which will include, as Bob mentioned, a core participant survey on prior authorization opportunities, helping us to prioritize and rank the opportunities that have been identified, implementer interviews, and vendor product assessment, and potentially site visits to ensure complete understanding of the current barriers to adoption and how operating rules might help that effort. Finally, after this advisory group has helped refine and created a really solid list of opportunities, we will be launching a prior authorization subgroup in early 2017, which will be open to all core participating organizations. So at the end of this year, an opportunity to submit feedback on prior auth through the core participant survey, and then to contribute to potential rule development early next year. A little more detail here on the prior authorization advisory group that's going to help refine that opportunities list this fall. It is a multi-stakeholder group. Members will be reviewing and providing feedback on the opportunities list, helping with key components of the environmental scan, participating in the interviews, and ultimately developing a really robust list of opportunities for a full core subgroup to vet. So we're really looking forward to sharing more updates on this effort in the coming months. At this point, I'm going to turn the call over to my colleague, Taha, who's going to talk about core certification.
Thank you, Erin. My name is Taha Enderwalla. I'm the Senior Associate for Core Certification at CORE. So first, I'd like to provide you all with an overview of what core certification really is. Core certification is the gold standard of what a certification program should look like. The main reason being is that the core certification program is a certification program designed by the healthcare industry for the healthcare industry. The core certification program is unique because it was designed with a set of checks and balances to assure it as the most robust and recognizable program of its kind in the industry. First, the requirements for testing, that is the testing that all entities must meet in order to be considered conformant with the operating rules, were agreed upon by 140 core participating organizations, which of course represents a wide array of stakeholders across the healthcare industry. Second, a third-party testing vendor, otherwise not affiliated with CORE, actually does the testing. And lastly, CAQH CORE administers the program and reviews the testing results and application according to robust processes and policies, and ultimately awards the CORE seal. So to date, CAQH CORE has nearly awarded 300 core certifications since the program's inception. As you can see on the slide, we awarded 14 new certifications in the past 2 months. And some of our recently core certified entities include plans such as Cigna, New Hampshire Medicaid, HealthNet, and HealthFlex, which is a dental plan. Further, we continue to have a strong commitment from organizations to pursue core certification. We nearly have 12 certifications in our pipeline, and some of these organizations include GE Healthcare, Aetna, and DSC Systems that are continuing to seek core certification. If any of you are curious to know if your health plans, trading partners, or vendors are core certified or in the process of becoming core certified, you can view a complete list of these entities by visiting our website and navigating to the core certified organizations webpage. So next, I'd like to talk about some exciting core certification trends occurring in the industry. This graph represents the growth of certifications by two industry groups, Medicaid plans and dental plans. So as you can see, certification has gained momentum in these markets, with close to 50 Medicaid certifications and 6 dental certifications. This shows the reach certification has and the operating rule adoption has across the entire healthcare system, and also shows that not only can entities benefit from operating rules from commercial medical plans, but benefits of the operating rules can also be seen with public and dental payers as well. So next, I'd like to talk about phase 4 certification. So phase 4 operating rules, as mentioned, have been completed and are currently being implemented by industry leaders. And I think we saw in the poll about 4% of you have already implemented the operating rules. Similarly to core certification for phases 1 through 3, CAQH 4 will be offering certification for phase 4, which should be launching soon. We encourage those who have already certified on phases 1, 2, and or 3, or those in the process of seeking certification, to get the complete package and to be among the first to become phase 4 core certified, to demonstrate that your organization is maximizing the efficiencies afforded by all the operating rules. Further, for vendors, this would be a great way to assure your customers that you are using industry-developed business rules for data exchange. So that's what I have for certification. And next, I'd like to introduce you to our next speaker, Glenn Lowe's, who's the Managing Director at CAQH Core. We'll talk about the future focus of Core.
Good afternoon, everyone. Thanks for coming on today's call. There's been so much tremendous progress made by the industry to come together and figure out how we streamline transactions in healthcare. And we're out of this inflection point where we have the concepts of standards, we have the concepts of operating rules. We are now working through adoption of those, both I think on both a mandated way and a voluntary way, as well as then evolving our payment models from a fee-for-service to a value-based payment model. So the core board, which is multi-stakeholder executives representing the health plans, provider, and vendor communities, plus advisors from the standard-setting bodies and others, have really been focused on where is Core going to be placing its efforts moving forward. You already heard some of the work that we're doing to maintain a very focused and quality effort around the designation we have as the HHS operating rule author, but we're also looking at where can we continue to add value to the industry. All the core participants want to lead and move ahead and change the market for the good, so how do we support that process? So one thing that we're going to speak about right now is market share. I think you heard from Taha about the certification, and we obviously heard from Bob and from Omni about, and Aaron, about the existing rules. We need to make sure as a market we're getting those fully adopted. So what we did do is do an analysis of the core certifications to date, and we focused first on the health plans, and we'll talk about some next steps. So the objective was to determine the number of covered lives currently benefiting from the health plan phase 1 through 3 certifications, and then figure out both where do we need to focus our public health plan certification efforts, so entities that are Medicaid and Medicare Advantage, as well as commercial, whether they be national health plans or regional health plans. So we looked at a whole host of information to gather up what percentage of the U.S. market is covered by commercial health plans and what percent is covered by public health plans.
and we estimated the core certification market share after looking at that coverage. So you'll see that on the next slide, we have great progress with phase 1 and 2, 76% of the commercially insured, at 76%, so pretty high percentage, are already covered by a core certified health plan with a commercially insured. And for the publicly insured, about 44%. And just as a reminder, you know, our data showed, and we can give you the detail of this, about 66% of the U.S. population is commercially insured, and about, you know, the other, about 34% are publicly insured, and we still have 10% aren't. So we're looking at a total, and we're really looking at a high percentage of health plans that are starting to become phase 1 and 2 certified. So very good news. As we move down to phase 3, the numbers drop. We're at 23% of the commercially insured and 23% of the publicly insured. So more work to do there. And if you think about it, the commercially insured is a bigger percentage of the market, so that 23% represents more of the covered lives. But still 23%, we both need work in commercially and publicly insured. So if you go to the next slide, this is what we'll be doing moving forward. I think you'll see on the left, we already talked about the substantial phase 1 and 2 market share demonstrated by the health plans. And many of those health plans, because of how core certification works, they're trading partners. If they rely on, if the health plan relies on them at all, they are also core certified. So great progress. Go to the CAQH website, see all the health plans, see the trading partners that are core certified. We need to work together as an industry to continue to drive adoption of phase 3, that EFT and ERA. There's been some promising signs. Cigna, for instance, and it's a large national health plan, just became phase 3 certified. Aetna just submitted their pledge. And a lot of other good progress. You can see, like New Hampshire Medicaid just became certified. Taha updated you on some of that. The pledges are continuing to move in, as well as the certification. On a third area, we're going to be working to target those that are not yet certified to become certified. And that not only is going to be the health plans, but also the provider-facing vendors. The industry, the health plans are making progress. We need to continue to make more progress. Some of the vendors and the clearinghouses, we need to continue to focus in on making sure that the provider-facing vendors are also certified, so they're getting all the information. And we will be coming out with an analysis of what percentage of the provider-facing vendors are certified as well. So update on that, and again, please call us if you'd like some more detail on the analysis. The next section on the future focus is, I think Denise already mentioned, there is a standard that yet has to be adopted that was required by the ACA, attachments, and it was actually required even before the ACA in the original HIPAA regulation. And we did get a recommendation by the industry from NCVHS, which is advising the Secretary on these areas. You can see a link to that letter. NCVHS did recommend some specific standards and then some overarching themes that you can see on this slide, giving the definition and scope to the transaction, making sure it's being implemented in an incremental way. It is overwhelming amount of attachments right now, which are additional information needed to complete a transaction or on paper. We're talking, you know, anywhere between 10 to only 20% are electronic, if that, and in many markets it's 0. So we have to do this in an incremental, thoughtful way and align up with clinical efforts, because many of these attachments are clinical data. So core activities on this moving forward. In the past, CORE has conducted an extensive research and done outreach, and that is up on our website. There's a whole host of data that CORE collected about where the market is, and additionally, we have testified to NCVHS about a need for an incremental approach to adoption, because we can't just flip a switch and go fully electronic in this area. We're continuing to monitor and work with some of the key standard-setting bodies in this area, And then in 2017, you're going to see a whole series of sessions that CORE will be hosting with experts about what are some of the standards in this area, where are they in the life cycle of development, what are some case studies of successful implementations, what value have they brought in, having some interactive sessions to ask the industry, both core and non-core participants, about where do they think these incremental steps need to be. And this will help the core participants prepare for any mandated effort that may happen if HHS issues a rule, which it may or may not in the coming year, or a voluntary effort. The core participants did want to wait for a standard, but I think they're also eager to continue to move forward. So what can they do on a voluntary basis? Because I think, as Humana recently said, it's up to us as an industry to figure out how we are going to be moving forward with or without regulation. So stay tuned for more information on that and send us your suggestions. And with that, I am going to hand it back over to Drew for thoughts on the webinar.
Great, thank you. And this brings us to our third and final polling question. And carrying with the theme of attachments, this question asks that CAQH CORE will be hosting a webinar series on attachments. And because of this, what topics would you like to see covered during these webinars? And we'll pause for just a brief 20 seconds or so, and please feel free to log your answer. Take about 10 more seconds. Try to have more than half the attendees respond to these polling questions. All right, 2 more seconds. Log in your answer, and I'll share the results. And Gwen, and then probably Jessica, I might have you comment on the results. I'll close the poll and share the results. Well, we hear you loud and clear. 70% say all of the above for this webinar series. Gwen or Jessica, what do you make of these results?
All I have to say is we're going to be busy. Gwen, what do you think? There's a lot of interest in these subsets of areas.
Yeah, I would agree, and I think this probably is representative of the fact this area is so interrelated, and we can't look at it in a vacuum. We need to look at it as to how the pieces are going to complement each other. So this is very informative. If you do have subject matter experts or really other specific topics or ideas for a venue, there's going to be a whole series next year. Send them to us. So as we're planning, and we are working with a range of experts to really plan out that series. You're going to see the whole series on our website, and we'll continue to adjust that, but you'll see them way ahead of time. Thank you.
Great. Yes, thank you everyone for participating in that. So we will carry on with more value-based. Take it back to you, Gwen.
Yeah, we're going to wrap up with value-based. So we can already see there's a lot of work that needs to happen for the activities that are already on the industry's docket, continuing to do the maintenance, driving the adoption so we get the full value, and then making sure we finalize that vision that ACA set out and HIPAA set out. So now we're really at a place, though, where value-based payments and alternative payment models are going to be our reality. Some estimate within 5 years they'll be in the majority of the payments. Some say it's going to be more 10 or 15. The core board really sees a focus on both fee for service, continuing to drive down the unnecessary cost for those transactions, as well as new needs for value-based. So all these exchanges continue under the value-based model, but they're different. Every one of these transactions may evolve. So we have started a project that began at the end of last year about looking at secondary research in the board dialogue to identify opportunities. We've been conducting primary research. We've interviewed a range of experts and continue to study the secondary research, like the announcements from Medicare on their use of alternative payments. We'll be publishing this quarter an interim report on that feedback to the core participants and asking them Does the feedback seem appropriate? Are there other experts we should be interviewing? And then once we get that feedback, that will be refined, and we will determine, is there a role for CAQH Core in this area, or for others in the industry to take that CAQH Core could support. And we'll be working either within Core or partnership to support others, or in partnership with those other entities. So exciting times, I think, because we're getting ahead of the game versus waiting for the problems to arrive. So really designing that early on. These were the top 7 areas that came out of the secondary research. Common data set, I think this is not a big surprise. So how do you define a patient and population? Standard terms for actually provider and patient and beneficiary identification. Infrastructure rules, this has been an interesting one. You know, how fast does the claims data get delivered in an alternative payment model? Things like that we've seen with a fee-for-service. If everyone was following the same rules, it would be positive. Process rules, and then libraries and cataloging for things like quality measures. To date, you'll see on the next slide, these are the structured interviews, a whole host of entities. Just yesterday, I know actuary was interviewed from a large national health plan. So there's been a whole host of entities that have been interviewed from all different segments of the industry, all different regional centers, as well as some that have maybe not successfully entered into the alternative payment world, so ACOs that did start and then shut down, as well as entities with HIEs and non-HIEs. So right now, this is on the next slide, you'll see from the initial primary research, the highest interest is some of the common data sets, patient risk stratification, and definition of standardized terms and other data sets. Moderate interest from some of the middle areas, and then lower interest from the quality measures. Other entities are addressing these areas per the research, and again, we're going to continue to dig down more. And then you'll see some of the several barriers that have been identified that they need, the industry feels it needs to tackle these barriers if alternative payments are going to be able to work smoothly and streamlined with the industry. So you'll also, this is an example, just to wrap it up. When we say common data sets, one example that has come up consistently is provider data. Providers and who you see and which providers serve which patients become more and more important with regard to value-based and alternative payment models. So narrow networks are increasingly used. So how do we make sure those networks are managed and the data is available? Member attribution, contract management, and provider directories, because which providers are in which networks will matter in making sure everyone has that information. So that's an example of a data set. So if you're a core participant, you're going to see the detail behind this, and we're looking forward to getting your feedback. And if you're not a core participant, you'll be hearing from core next year how it will be moving forward. Thank you, Drew.
Thank you, Gwen. Now we have some time for Q&A. I'd like to remind you to please submit your questions by typing them into the questions panel of your dashboard. I think this question's for Denise. We got a few questions about the status of the certification of compliance rule, and I know you talked about it earlier in your presentation, but I think the reason why there's a little bit of confusion is that, you know, the original rule had a deadline. That deadline has now passed. Can you kind of walk us through what that means?
Sure. The original statute called for health plans to demonstrate their compliance with with certain HIPAA standards and operating rules, and I believe that the cutoff was January 1st of 2015. Well, of course, that date has come and gone. CMS and HHS actually have some discretion in terms of meeting those statutory dates. And sometimes they get some pressure from Congress to meet certain dates by a certain time, and other times they take a more relaxed view of it because they understand that sometimes other priorities come up. In this particular instance, the exchanges were the primary focus for CMS for a good number of months. So that being said, the other issue that was in the proposed rule that came out in 2014 was the use of the health plan identifier, the HPID. Since that time, CMS has decided that perhaps the HPID may not be the best way to enumerate controlling health plans, and they've kind of put that on hold indefinitely. So you have those two things combined. And again, in an election year, there's a lot of reluctance to initiate any new regulations because they are subject to immediate review the minute that a new president is inaugurated and takes the oath of office. There also is a cutoff approximately November 1st, at which point the Office of Management and Budget, which has to review all regulations, states that they will no longer accept any kind of regulations unless they've already been pre-submitted. So you have all of these things coming into play. So the best that we can know right now is that according to the Unified Regulations Agenda that HHS publishes in the fall and in the spring, the last thing that we saw was that this particular topic, this health plan certification, was on the docket for Q2 of 2017. But again, that's always subject to change.
Thank you, Denise. The next question, Gwen, I think this is kind of a reading of the tea leaves question, but can you give us, kind of where do you see this attachment standards? Do you think it's going to happen? Kind of what is the outlook on whether something will happen with the attachment standard? Do we know?
No one knows except for time, right? But I think similar to the certification regulation that Denise just spoke about, both of those, if there is a federal requirement, they need to come out of HHS. And right now, we're going through an administration change, and we will have a new set of leaders within the government starting in January, and they may need some time to familiarize themselves with their priorities before they put anything out. So we may see something from the government late next year, but time will tell. And I think NCDHS was very thoughtful in its desire to having an incremental approach. We're at an extremely paper-based world right now. We've gotten great adoption due to high tech of electronic medical records. And so how do we take the progress with electronic medical records and potentially take advantage of that as we think about the need for attachments for claims, because again, many of those are clinical attachments. And HL7 standard was going to be absolutely essential to that, and thoughtful regulation from HHS about how to move this incremental way.
Thank you, Gwen. The next question is for Omni, and the question is, why are there so many CAQH code combination changes? What real-world changes are driving these code changes?
That's a great question. So the CAQH code combinations, as Bob spoke to, the code combinations build on the standard CAQH list. So the changes to the code combinations are generally in response to changes that come out of the code committees that are made to the standard list. And what we usually find, so when there are a large amount of changes to those, there are a large amount of changes, obviously, to the code combinations. And what we find a lot is statutory or other changes can drive those adjustments to the CAQH list. So, for example, a new set of CAQH lists actually came out this Monday. It included a new CARC additionally to address a narrow network situation, as Gwen referenced, for when members go to a provider that is a preferred network, so they get a reduced benefit. So there's a CARC coming to that to address these evolving payment models. There was a new ROC to address specific statutory requirements under Social Security that applies to Medicare, so new statutory things come up. We've also had experiences with our tax group where the tax groups have had experiences adjudicating a code combination. The description is difficult for that, so they've gone to the code committee themselves and asked for changes. So it's other things that kind of trickle down to the closed combination.
Thank you so much, Omni. Taha, the next question is for you. The question is, can you certify a product specifically for core phase 4 without first certifying for the earlier phases?
That's a great question. So yes, a product can be certified specific to the transaction that you conduct. That's specific to vendors and clearinghouses. So if you have a product that does the claims transaction and the prior authorization transaction, you do not necessarily have to go through phases 1 through 3 certification. You can certify for phase 4. But I'd also like to point out, if you're a health plan or provider, you do have to go through the sequential process of becoming certified for each phase.
And if this is complicated and people have any questions,
feel free to contact core at CAQ or core at CAQH.org.
Great. So another question, forgive me for the pause, I was having a little bit of a hard time reading. So a question came in, will there be changes made to the phase 4 operating rules based on recommendations from NCDHS? And I think what this means is based on what the Secretary decides to do with the NCDHS recommendations. If the Secretary recommends changes, what would happen?
This is when I'll take a shot at that and others kind of chime in. Obviously, the core participants felt like it was very important to have a foundational set with the transactions in phase 4. And some of those transactions, the foundation was needed because there is not a lot of adoption, so getting the basics in mind. So the core participants are fully supportive of the basics, and there's actually, I want to believe, correct me if I'm wrong, I think it was over 90% approval by the implementers that represent 75% of the commercially insured that approve those rules. So as the industry, they really do feel like the basics are needed. Everyone wants to do more because we have to do more if we're going to, going back to the billions of dollars that Denise highlighted at the beginning. If you get to the billions, if you're going to get to the billions of dollars of the savings, we have to do more. So we would welcome, and I think you're already seeing from what Erin presented with the prior authorization, CORE will welcome doing more and figuring out how best is required by the ACA to continue to build on both the operating rules and standards that are already done, continuing to build on them to have more appropriate national expectations for the data exchange.
That's a really good point. Thank you, Gwen. So I think, I'm not sure whether this last question is for Denise or for Taha, but it's a question related to what Denise was talking about with the asset system. So when will, those penalties for phase 3 start to kick in? Do we know anything about that from CMS?
Well, I'm not sure exactly the nature of the question, but it sounds like if you do have a complaint or you're not in compliance with phase 3, what is, I guess, the timeline that you have in order to become compliant before you get hit with a penalty? The CMS administers the asset program, which is a way for entities who have problems with HIPAA-covered entities that are not compliant with any of the HIPAA-adopted standards or operating rules to file a complaint either anonymously or by identification. And CMS takes a very proactive stance in terms of not necessarily slapping everybody with a penalty right off the bat, but working with both entities, the complainant as well as the entity that has the complaint against them, to bring it to compliance. That's their goal. When I was at CMS and had jurisdiction over this particular program, I think we only came close once to actually doing a monetary penalty for a HIPAA noncompliance. So it really depends in terms of how the case is worked. Once the complaint is reviewed, it's determined whether there is a valid issue. the CMS gets both parties together and tries to adjudicate the situation. And this can take, in some cases, they try and get it done within maybe 2 months. Other times, you can get a 6-month extension if you are the party that has the complaint filed against them in order to achieve compliance. So it can take as little as 30 to 60 days. It could take as long as 6 months, and then beyond that, again, depending on the nature of the complaint and the violation.
Thank you, Denise. And it looks like we're out of time today. I'd like to thank everyone for joining us. A recording of this session will be available on our website within the next 24 hours, and it will also be sent to you in an email, so please share it with your colleagues. A list of the upcoming webinars are on your screen. Please, register and join us. We've got some very interesting topics coming up. In the next slide, we've got some of our e-learning tools that we are offering to you, and we're working on some new ones, so we hope to have some new information that will be useful to you in our various programs and topics. And finally, this is a way to engage with us. There are various links to engage with us. And thank you for your time. Have a good afternoon.